everybody. Welcome to our grand rounds. As you know, last week we made a last minute decision to do a part two of our Omicron update. I think everybody knows that we are seeing reduction in rates in the community. Unfortunately, that hasn't translated to a reduction in hospital. We really have plateaued and are seeing ongoing onslaught of, anywhere, at least at the university site, 8 to 10 admissions, and then there's the outbreaks and so on. So still a lot of pressure on the healthcare system, and with everybody pitching in to help out on the COVID units, I think it's really important that we have the information we need to look after these patients. So with that, I'm just going to briefly remind folks that we have Dr. Stephanie Smith from the Division of Infectious Diseases. Stephanie is Professor and Director of Infection Prevention and Control at the University of Alberta Hospital and Mazantowski. We have Dr. Lynora Saxinger, who's Associate Professor in the Division of Infectious Diseases. And of course, she has been running the scientific advisory group for the COVID-19 Emergency Coordination Center as co-chair. And finally, we have Dr. Robyn Harrison, who is a clinical professor in the Division of Infectious Diseases. And she is a communicable disease consultant for the AHS Workplace Health and Safety Program. So we did hear from Robyn last week, and I don't think she'll be presenting very much today, but we asked Stephanie to present her part related to infection prevention and control, and then Dr. Saxinger will be presenting a little bit as well, and then hopefully we'll have lots of time to answer all your questions. So with that, and Dr. Smith is going to be on audio, not on video today, but just really want to thank the three of them for coming back and agreeing to do this. So with that, I'll hand it over to Dr. Smith. Good morning, everybody. Welcome to our grand rounds. As you know, last week we made a last minute decision to do a part two of our Omicron update. I think everybody knows that we are seeing reduction in rates in the community. Unfortunately, that hasn't translated to a reduction in hospital. We really have plateaued. And are seeing ongoing onslaught of, anywhere, at least at the university site, 8 to 10 admissions, and then there's the outbreaks and so on. So still a lot of pressure on the healthcare system, and with everybody pitching in to help out on the COVID units, I think it's really important that we have the information we need to look after these patients. So with that, I'm just going to briefly remind folks that we have Dr. Stephanie Smith from the Division of Infectious Diseases. Stephanie is Professor and Director of Infection Prevention and Control at the University of Alberta Hospital and Mazantowski. We have Dr. Lynora Saxinger, who's Associate Professor in the Division of Infectious Diseases. And of course, she has been running the scientific advisory group for the COVID-19 Emergency Coordination Center as co-chair. And finally, we have Dr. Robyn Harrison, who is a clinical professor in the Division of Infectious Diseases. And she is a communicable disease consultant for the AHS Workplace Health and Safety Program. So we did hear from Robyn last week, and I don't think she'll be presenting very much today, but we asked Stephanie to present her part related to infection prevention and control, and then Dr. Saxinger will be presenting a little bit as well, and then hopefully we'll have lots of time to answer all your questions. So with that, and Dr. Smith is going to be on audio, not on video today, but just really want to thank the three of them for coming back and agreeing to do this. So with that, I'll hand it over to Dr. Smith.
Thanks very much, Norman, and thanks for having me and for allowing us to present this week in addition to last week. So I'm going to just pick out, I think, a few kind of key things that I think are important in terms of, what's really different about the Omicron wave. So next slide, Andrea. So I think, all of you are aware that this variant is slightly different in that it has a larger number of mutations, 50 amino acid altering mutations, 36 of which are in the spike protein. And again, we don't have a huge amount of data given that we've only really known about this variant for a little less than 3 months, but it does appear that there's increased ability of this variant to attach to the ACE2 receptors in the upper airway. And so, the thought, part of the reason that we think that there's increased transmissibility is that theoretically you could have a smaller inoculum needed to cause infection. But I think it has been clear that there's decreased virulence compared to Delta, and that's probably a combination of some vaccine protection, although we know that that is lower than with Delta, but also potentially a decreased ability for the virus to replicate in the lower airways. So we're really not seeing as many people coming in with that kind of typical COVID pneumonia. And I think Robyn talked about some of the differences in clinical presentation last week. Next slide. So again, just to give you kind of a sense of how the Omicron lineage is different from Delta. So you can see the orange and kind of red dots. And so those are that's the BA1 and BA2 Omicron. And so again, they're vary quite significantly from the green dots, which are Delta and previous iterations. Next slide. And so I think all of you are well aware of the situation in the hospital. So as Norman said, we do seem to be seeing community cases declining, but we continue to see quite large numbers of people being hospitalized. And certainly we've seen more hospitalizations with Omicron in this wave than we have in any other wave. So we're up to, as of, I think, day before yesterday, 1,600 patients are in the hospital. Next slide, please. So just in terms of the IPC parts, I'm just going to pick out kind of two things that I think have changed, and I think we have to understand why they've changed and what data supports those changes. So I think most of you know in the community, there's been a change to 5 days of isolation for those who have had 2 or more doses of vaccine. And in the hospital, we have decreased the isolation duration to 10 days for those who have incidental COVID, meaning that they aren't coming in with typical kind of COVID pneumonia. We still continue to recommend 21 days of isolation for those who are immune compromised or those who are critically ill with COVID. So, some significant differences in the isolation duration in the community has been cut in half. And then additionally, with our PPE, there's now a recommendation to wear an N95 respirator for suspect or confirmed COVID-19. And for visitors, the recommendation is to wear a best fit or an N95 that's non-fit tested or a KN95 when coming into our hospital and seeing COVID positive patients. Next slide, please. So again, isolation duration, is Omicron really different? So just to kind of frame this, I think there's two ways really of measuring duration of viral shedding. So one is using PCR testing and using the CT value or the cycle threshold value. And there's certainly some data that would suggest that a cycle threshold value above 30 suggests that there's less chance of forward transmission, and there's really small amounts of viable virus. And we see that CT values tend to be highest at the very early onset of infection and then gradually decline over somewhere between kind of 5 and 10 days. And then the gold standard is really viral culture. So actually seeing if the virus is viable. And so in terms of, what data do we have around this with Omicron and with other variants? And so from early pandemic studies, we certainly do have some data showing that PCR positivity can last for many weeks, but viral cultures really tend to be negative after the first 8 days. And so this was a study in Nature fairly early on in the pandemic that nicely illustrated that, where you basically have no viable virus after day 10. And we actually now have human inoculation studies. So one study that is still in preprint, but they inoculated 36 healthy volunteers with wild type SARS-CoV-2 strain. And so they could actually see, they knew exactly when they were inoculating them, and they could look very closely at the viral kinetics. Next slide, please. And so basically, what they saw is they did serial testing of nose and throat, and they monitored the viral load. They also did viral culture. They looked at symptoms, and what they found is that the viral load peaked kind of 3 to 4 days post inoculation. And again, this is wild type. But you can see there's a fair amount of variability, but most had, and again, the red is viral culture, the blue is PCR. And so you can see that most people did not have viable virus after day 10 to 14. Next slide, please. So, of course, the question is, well, is this different with Omicron? All of a sudden, we've shortened our duration of quarantine or isolation. So is there actually science to back this up? And I just picked out a couple of studies because there's really not a lot of data on this yet. But this is a Japanese study that looked at 21 patients, and all of these patients were admitted to an isolation facility, and they had, again, serial testing. So most of them were vaccinated. They only had 2 that were unvaccinated, and most of them had mild disease or were asymptomatic. Next slide, please. And so what you can see here is basically in the first column you have PCR-based testing, and in the second column you have viral culture. And so you can see that even at 7 to 9 days, most people are still PCR positive, which is not surprising. Only about 10 people or 10% of people are viral culture positive, but at 3 to 6 days, almost 40% of these patients still had viable virus, which suggests that the 5 days there probably is still some viable viral shedding after 5 days, and we do need to be careful, and I'll talk about that a little bit more later. And then next slide, please. And again, we have to take all of this with a grain of salt. This is the asymptomatic patients. And again, there's only 6 of them, so really small numbers. But you can see that it does seem that there's less viable virus at 6 to 9, none at 6 to 9 days, and only 50% at 0 to 5 days. So it does appear in this very small study that asymptomatic individuals do tend to shed less virus and shed it for shorter periods of time. Next slide, please. So, what other data do we have given that's a study of 21 patients? And yes, it has viral culture, which is the gold standard, but it would be nice to have maybe a slightly larger study. So, this is a study, again, a preprint, but it looked at PCR positivity and CT values over time as a surrogate of viral load. And potential infectivity. And again, they basically looked at the cutoff of 30 as uh, basically saying that a CT value over 30 does not result in forward transmission. And next slide, please. And they did compare Delta with Omicron. So the blue is Delta and the red is Omicron. And you can see, I think, the general trend is that for both Delta and Omicron, most people are have a CT value below 30 at kind of 5 to 6 days, but there's a huge amount of heterogeneity. So, there's certainly a proportion of people that continue to have high CT values out to day 10. And it really doesn't seem to look all that different between Delta and Omicron. And just to give you some context, these were generally healthy patients, often asymptomatic, because this was done in the NBA players. And so I think, again, it does suggest that, when we look at viral loads, they're not appreciably different between Omicron and Delta. Next slide, please. So I think, my conclusion from looking at this data is that the change from 10 days to 5 days is really a pragmatic approach. There still is, albeit lower, but potential risk of transmission between days 5 and 10. And really, I think the change was made to basically allow the workforce to continue to function, given just the, incredibly large numbers of Omicron in the community. And so, and I think, there is some data to suggest that those who have had 2 or 3 doses of vaccine and are asymptomatic may have shorter durations of viral shedding. But I think it highlights the need for, these layers of protection. So yes, we've changed from 10 days to 5 days, but I think certainly in the hospital and even when you're interacting in the community, we need to be diligent about our PPE, and that includes with patients and with colleagues. Next slide, please. So what about PPE? So I think all of you are aware that there were new interim guidelines released from a variety of sources, including Public Health Agency of Canada, Public Health Ontario, and AHS. And really that's based on the concern about the increased transmissibility of Omicron and this desire to provide optimal protection. And so there's recommended use of N95 respirator when in contact with those with suspect or confirmed COVID, or in high-risk areas such as outbreak units and emergency departments. And there is a caveat, at least in the AHS guidelines, to say the use of the N95 should be based on point of care risk assessment. And what does that mean? Basically, if you deem your interaction to be of low risk, so you may go into a patient's room just to ask a question, or you're going to be in there for all of 10 seconds, it might be reasonable to wear a surgical mask. But certainly, if you're going to be spending prolonged period of time in a room with someone on COVID precautions, then N95 would be necessary. Next slide, please. So what is the evidence for this? So certainly, there's been a huge amount of studies looking at kind of aerosol spread in the community. And there's been a number of simulated studies trying to look at how aerosols behave and, what affects them. So certainly, we've seen case reports of presumed aerosol spread in the community in churches and that kind of thing. We haven't seen as much evidence of aerosol spread in the hospital, and that's probably because we have better ventilation and we have continuous use of PPE. But as I said, there certainly are higher risk scenarios where an N95 is going to provide better protection. And I think, things like duration of contact and closeness of contact are important factors in transmission, but there's certainly a number of gaps in terms of how aerosols behave. Next slide, please. And there's a couple of new studies that have really tried to look at this, I think, in in a more detailed way, and I won't belabor this because it's a fairly technical study, but this study actually used a fairly novel approach in terms of trying to simulate SARS-CoV-2 aerosol droplets over time, and they looked at how things like humidity and temperature and light and pH and shape of droplets and the amount of carbon dioxide and particles would affect the behavior of SARS-CoV-2. And so it was certainly a much more refined approach to previous experiments. Next slide, please. And so this is basically they kept these particles or SARS-CoV-2 particles between in an electric field, and then varied the temperature, the pH, etc. Next slide, please. And what they found is that, if the infective virus falls to about half after 5 seconds when there's low humidity, which would be winter in Alberta, certainly, and decreases further, but more slowly to 34% at 5 minutes. But at high humidity, like 90% humidity, then it certainly can stay in the air for longer periods of time. But I think that, and both high and low relative humidity, 90% of infective virus was gone from the air at 20 minutes. And then there's, further impact of pH and temperature. And so I think this highlights the fact that, we've heard about how SARS-CoV-2 acts like cigarette smoke. It kind of hangs around in the air for long periods of time, or it can stay in the air for hours. And I think we still have a lot to learn in terms of exactly how it behaves and how long aerosolization is present, and how much that contributes to transmission. Next slide. So I think that we need to recognize that transmission can occur through aerosol, through droplet, through contact. And so the real key is that you have a well-fitting mask, eye protection, gown, gloves. They're all going to provide some protection in caring for someone who has suspect or confirmed COVID. And really, we need to focus on the bundled approach. Next slide, please. And this is just, kind of evidence that we can't throw out our hand washing. So we examined the survival time of, in the study, they examined the survival time of all strains of SARS-CoV-2 on plastic and skin surfaces. And they also analyzed the efficacy of alcohol to inactivate the virus. Next slide, please. And what they found is that certainly, especially with Omicron, it can actually survive for many hours. This is cultivatable virus, can survive for many hours on plastic surfaces and up to 20 hours on skin. So again, I think that it's that bundled approach with PPE and hand washing is still important. We can't entirely throw that out. Next slide, please. So I think the take-home points from this, duration of infectivity may be longer than 5 days. So we do need to be careful with our PPE if infected and returning to work after 5 days, or if you're in close contact with a COVID positive case, and that all PPE is important. So I think, again, there's been a lot of emphasis on aerosol spread, but I think it's still important to clean your hands, protect your eyes, clean your equipment, etc. Next slide, please. So that was all I was going to say. There was one question from the audience about detection of Omicron throat versus nasal swabs. And so there's been a couple of good studies that have looked at this. One study from South Africa that looked at 382 patients, and they took swabs from saliva and mid-turbinate and found that Delta actually had a higher chance of detecting it from mid-turbinate, whereas Omicron actually had a higher chance of detecting Omicron from saliva, so suggesting that saliva or throat swabs may be more sensitive for Omicron. And then a little closer to home, next slide, please. We have a study from Nova Scotia that recruited 1,472 volunteers from a rapid testing location. And this was actually using the antigen based test, but they did combine PCR testing as the gold standard. And what they found was that the sensitivity for combined throat and nasal swabs was actually higher than for either one alone. And so I think that most of us that are doing our rapid testing at home now do a combination of throat and nasal sampling, as it does increase sensitivity, although it's not in the product monograph. Okay, and that's all I was going to say, but I'm happy to take questions.
Stephanie, I'm going to jump in before Lynora asks, and I'm sure people have heard that in China, they're actually doing anal swabs as well. Do you have any comments on that one?
Yeah, I mean, I think that we know that we can detect COVID in or SARS-CoV-2 in waste, and we have our whole wastewater program in Alberta that we're using as a surrogate of community spread. So certainly that would be another way of detecting SARS-CoV-2. I think that realistically, we can get fairly good sensitivity if we're using that combined throat and nasal swab. So I'm not sure that we would be going to anal swabs at this point in time. And I haven't seen a lot of data actually doing head-to-head comparisons.
Thank you. Lynora, before we go into the questions, did you want to jump in and do your part? Lynora is actually on service, so I don't know if she's on a call or what, but we could maybe do some questions if she's tied up.
I actually surprisingly have some kind of slight differences in where I think the treatment algorithms are going to be going over the last week. I guess that's not that surprising. It has been very challenging, and I guess my week on service has helped me kind of refine what I see as the bigger questions. This has been the current draft of kind of a guidance document that was last updated January 27th. It's under review again. Part of the reason it's under review is actually we've been requesting some data that should help us stratify our risk approach a little bit better, and that's been coming in. The other thing that has been changing is that the supply of some of the medications suggests that we really do need to try harder to target the most important people. So although this is still officially there, I will just comment that it will be under revision, and I'm going to try to highlight where I think it's going to go. And so this is going to be more principle-based than detail-based. I know a lot of people have been great about looking at the wording of the criteria when they're trying to apply them. So this is a little bit more about the why. Just reminding people that when we have nosocomial or incidental cases of COVID in the hospital, which we do see quite a lot of, so individuals are being admitted for something unrelated and they're found to have potentially minimally asymptomatic, quasi-symptomatic COVID. We have to decide what to do with them in addition to isolation. And then also people who have acquired infection in hospital, obviously we need to decide what to do with them too. And in my head, I kind of keep those people in the same bucket as I would keep an outpatient because they are not there for COVID. And so they should actually meet the same criteria that we would use if they were a community dwelling person. And that approach really does focus on reducing the risk of progression to severe disease. And it's a risk-based approach. And so the idea is that you have to identify, after you identify the case, you stratify for the high risk, and then you have to deliver therapy. In the community setting, IV sotrovimab, there's an infrastructure that's been worked out that works pretty well. The PO Paxlovid infrastructure is kind of layered into that. It's somewhat similar in the way it's assessed, and it's not something we have to worry about prescribing right now. And then eventually molnupiravir will probably be the same. The community-based oral therapies will probably also see development of processes to expand the prescriber pool, but right now the limited supply means that's not as relevant. And I'll just point out that the mild COVID therapy, so the outpatient no-O2 therapy guidelines do vary a lot between jurisdictions because the evidence is kind of unclear on things like, budesonide, fluvoxamine. Sotrovimab has very good evidence and it has very similar criteria across provinces. Paxlovid is going to be layering into similar criteria with varying degrees of support across provinces, and that's not going to be as relevant for us in hospital. Sotrovimab would be the drug that would be most relevant for us in terms of early therapy for high-risk individuals, and the way that sotrovimab had been studied was in unvaccinated people who were adults who had a comorbidity that's known to give increased risk, or they were age over 55, regardless of comorbidities, identified COVID positive within 5 days prior to receiving medication. And the outcome was all-cause hospitalization or death. In that population, death was 1% in the treatment arm versus 7% in the placebo arm. So that was mostly hospitalization, which is a 6% absolute reduction in the number of people hospitalized, which wouldn't make that much difference. I think if you applied it to an entire population completely perfectly, you'd still have a lot of people coming into hospital, but it does reduce the risk. It's an 85 relative risk reduction for the individual. Number needed to treat to prevent hospitalization is, kind of 15 to 20. And the things here that I think are important that might have gotten lost, especially in the earliest iteration of guidelines that had come forward, were that this drug has only been tested rigorously in unvaccinated people, not in vaccinated people. And if you think about that, that means that if someone has been double or triple vaccinated and they already have antibodies on board when they get infected, do we actually think it is materially likely that adding more antibodies is necessarily going to change their course? And so that's an open question. There's not really data for its use in vaccinated people. Paxlovid criteria are going to be very similar. And so I kind of want to go over what my current unofficial approach is in hospital. So if you have a COVID positive patient who's under-vaccinated, so at the moment the data is kind of splitting out that 0 or 1 dose tracks very closely together in terms of risk. If they're asymptomatic, there's been nothing studied for that group. Monitoring would be appropriate. If they do have some symptoms, and it's within 5 days of the onset of their symptoms, they don't yet require oxygen, and they do have some risk factors for progression, like the outpatient risk factors we just looked at, you would consider giving those patients sotrovimab. And our sotrovimab supply is not too bad right now, so it's a very reasonable thing to do. So this would apply to a fair number of nosocomially acquired cases where they actually have some symptoms. And then confirmed COVID pneumonia, and those are under-vaccinated individuals, confirmed COVID pneumonia where they're actually needing oxygen. They have an infiltrate, they have oxygen. This is not likely to be a non-acute chronic process, and they are not progressing towards mechanical ventilation or requiring ventilation. You would be using remdesivir in that group because that group is where I think our limited supply is probably most high impact. In a vaccinated patient, very similar, you would just monitor people with no symptoms. If they are vaccinated, but they have very severe immunocompromise, which really is people who have untreated HIV with a low CD4 count, very severe and uncommon, frankly, immunodeficiency states like SCID or common variable immunodeficiency or profound hypogammaglobulinemia, transplant patients. So people where we actually think that they will not have had a good response to vaccine, you would look at their sotrovimab criteria. Then for COVID pneumonia, this is, the group where at this point they're actually sick, regardless of their vaccination status. You would treat them the same. And following on from that, I'm just going to point out that unvaccinated high-risk patient, or actually unvaccinated and vaccinated high-risk patients actually do remain different. As an example, in the most recent model from Alberta data from December, they actually looked at non-incidental COVID hospitalizations, risk of severe outcomes, and just an example of the difference, a 70 to 79-year-old with 3 comorbidities, a vaccinated person had a 13% at risk of a severe outcome, most of those would be hospitalization. Unvaccinated was a 79% risk, which is obviously much different, even in a group that you would consider to be at high risk. And so medication supply does become an important thing. I also wanted to just show you examples of some of the data that's being worked on. This is still a work in progress, so I wouldn't actually necessarily want you to use this elsewhere, but in an under-vaccinated 0 to 1 dose, under 70-year-old adult, probability of ICU admission. So this is the cleanest data we have. ICU admission for those hospitalized with COVID as a non-incidental diagnosis. If you're under 70 and under vaccinated, it's a 1 to 9% risk depending on your number of comorbidities. If you're over 70, it's an 8 to 39% risk, depending on your number of comorbidities. So obviously, that is a significant difference. In the vaccinated risk, in the vaccinated group, the risk of ICU tops out with 70 plus 3 comorbidities at 2%. So if we're looking at our supply in hospital, this is one of the things we want to prevent. We want to prevent people from progressing to require ICU. I think it's an easy thing to say that we should really be targeting a lot of that towards the under-vaccinated group. Then, of course, if people are progressing into severe COVID, increasing hospital oxygen requirements, or are coming right in this kind of state heading towards ICU, we will then start tocilizumab, and if that's unavailable, baricitinib or sarilumab. They all kind of work in a similar pathway. There's a little less data available for the latter two agents, but so far the data that's available suggests that it would be expected to have a similar beneficial effect. I wanted to touch briefly on the remdesivir, which we had not been using for quite a long time. And then this trial, which is a subset of the CATCO trial, came forward. We have lots of familiar names in the investigator group here, so that was a lot of work, thanks to my colleagues. So this is 1,200 people, remdesivir versus standard of care, 18.7 versus 22.5% mortality. The absolute risk reduction 3.8, that crossed one. And then mortality, however, was 8 versus 15% mortality difference, with an absolute risk reduction of 7%. So that's actually pretty considerable. And so that's the group that at the moment, I think the data supports targeting remdesivir too. Most of these patients were on oxygen. Oxygen is the area where it's the tightest data. So patient on oxygen are, the group that we think would be most important to give therapy. There's some other data that suggests within 10 days of onset is better. And then, of course, if we had a lot of remdesivir around, remdesivir works in a similar degree to other outpatient treatments like sotrovimab and Paxlovid in reducing an individual's risk of progression to hospitalization. But it has to be given over 3 days as an IV supply. And I think that the limits in supply right now make this really not a feasible thing to consider for outpatients right now. So I was going to wrap up there, but also we'll take a lot of questions, and we'll also take into account comments when we try to derive a better way to formulate recommendations to make them more user-friendly. For incidental or nosocomial, risk assess. If they're under-vaccinated, use sotrovimab if they would qualify as an outpatient. Patients who are on oxygen, both dexamethasone and remdesivir on top of dexamethasone have mortality benefit, and also remdesivir would be expected to reduce the risk of progression to requiring mechanical ventilation. For patients who are progressing, you wouldn't necessarily be using remdesivir, you'd be skipping that and going to dex plus tocilizumab, which actually has a bigger absolute risk reduction amongst the medications. And then the mechanical ventilation later presentations, if they've been on for a while and they have not received an IL-6 or Janus kinase, then you would be relying really on your dexamethasone. Now, I do have to comment a little bit about on the serology and Delta. There was a transition period where we were still seeing people coming in with Delta infection. I think that we're pretty close to saying we probably don't need to bother with this anymore. Sending the serology in case it comes back variant typed as Delta, the timing rarely works out, and the likelihood that it's Delta is very low right now. So although if you happen to know someone has Delta, you could consider doing this, I'm not sure doing the serology makes sense anymore. So that's all I wanted to say.
Thanks, Lynora, and thanks for coming back to do this on the week you're on COVID service. So really appreciate it. Okay, we'll give you a bit of a break, and I'm just going to ask Steph. There's a question about, we know there's a difference. Well, there shouldn't be, but there is always a gap between science and policy, I guess. And so one of the questions is around, there's a few questions around this, but one is as the community prevalence of Omicron is going down and the threat to the workforce recedes, Do you think that there will be a change to the isolation period recommendations to go up? So this is in the community from 5 to 10 days.
I don't. I think honestly going back is probably not something that public health will do. That's purely just my opinion. I think that I mean, yes, we are seeing decreased numbers of cases, but we're also seeing the vast majority of people in the community not having severe disease. So I think you have to look at all of these factors when considering what kinds of restrictions we're going to be putting on the population. So again, I mean, I think that yes, we know that probably transmission can occur after 5 days. It's less likely, and I think that again, this change was a pragmatic approach, and I suspect it won't go back.
And I guess just in follow up to that, in hospital, then, with all of our flow issues, for those who don't know, we are still well over capacity in the medicine program in the zone. And of course, PRU opened last week to help support that. But that has also been a little bit tricky in that we haven't been able to use it to its maximum capacity. So is there a consideration being given to inpatient isolation being reduced to 10 days, or are we going to stick with the 14?
I mean, we have reduced isolation to 10 days for those who have either asymptomatic COVID or, they're coming in with other things and they don't have the kind of typical COVID syndrome. So we do look at, every patient to see if we can reduce that duration of to 10 days. It's not, 14 to 10. I think it does make a bit of a difference. It's not a huge difference, but again, I think, we've certainly seen significant transmission between roommates in hospitals. So I think that we would have to be very careful with reducing it any further than that.
Yeah. Thanks, Lynora.
I was just going to say that, during this week, I've kind of perceived there are some people where they're kind of locked in by isolation to at least a degree in terms of being able to find out the best place to care for them. And one thing that I think from a scientific advisory group point of view and just data point of view that would be really valuable is we haven't really considered whether or not the role of the various therapeutics changes the likelihood of transmission in hospital. And so if someone has received antiviral treatment or monoclonal antibody therapy, it's plausible actually that might reduce their risk of transmission. And also transmission from vaccinated versus unvaccinated individuals in hospital. And so, I'm thinking someone should do that study. It would be, I think, of value to both track the literature in that domain and then also maybe consider if there's some ways we might contribute to the literature in that domain, because although we don't recommend retesting on a regular basis, one might imagine a sampling strategy of retesting with culture that would help us answer some of those practical questions, because they're actually both difficult and expensive questions, And if we knew, for example, that having received remdesivir reduced your risk of transmission to nil, that would change what we can do, and it would be important to try to sort out. So I'm just kind of tossing that out, saying, hey, does anyone know of any good funding opportunities and have any extra bandwidth? Because that would be a great thing to do.
So Ash Sonpar did mention in the chat here that they actually did, I'm assuming this was a study at the Royal Alec where they looked at viral, RHs, I guess, and it was 20 to 45% in the patient room. And so I don't know, Steph, if you want to comment on that. I don't know if you can see her comment in the chat box there.
I can't. Sorry, I'm having some technical difficulties. But I mean, I would say so. Ash's study basically looked at PCR and viral culture in patient rooms versus outside of patient rooms, really to get a sense of how, like when we're talking about aerosol spread, how much is it spreading? Is it actually spreading outside of rooms? And I know at the university, what we found is that you could certainly find and culture virus inside of a patient room, but we didn't really find it outside of the room. So it did seem to be maintained within the room. And again, most likely because of air exchanges and that kind of thing.
Dr. Kujek has asked about rapid tests. Yes, all healthcare workers, including physicians, will be receiving 2 rapid tests. They will be distributed by the sites. Unfortunately, I thought the ones for the university site were supposed to go out this week. Robyn is typing an answer here, but you should be hearing any day. All healthcare workers will be receiving a couple of tests. So, Lynora, I don't know if you want to attack this one. Do you know, have we looked at sort of the mechanism, I suppose, of action with Omicron in terms of the cytokine storm? Is it the same as what we saw with Delta, or, the fact that we're not seeing as severe disease? Has anyone actually looked at that?
I don't think I've seen a whole lot of data around that. I would say that the lessened severity of Omicron is probably due to a couple of different things. One of them is actually that it's occurring in a more highly vaccinated and highly previously infected population. So part of the impact has been blunted by the fact that there's differences across populations, and yet in most reports, people who actually do develop, severe COVID, it is clinically very similar, and it seems to respond in a similar way to the therapeutics. And so, to at least a degree, it looks like the mechanism of the inflammatory phase of the disease is maintained with Omicron, and that it responds in a similar way to our usual therapeutics. And certainly, I would say, even just from the last week, the unvaccinated people who come in look a lot like the unvaccinated people from prior waves. It doesn't necessarily seem, on that kind of a basis to be significantly less severe. So yes, I think that it's very similar. I was also going to ask, just to toss this out, because someone asked me and I didn't know, how you go about getting refit tested now that the menu of masks has changed. Because I noticed that there's new brands popping up all the time, and I'm like, I don't know whether that fits me or not.
Robyn, do you want to jump in? Thanks.
Sure. Thanks. Whoops. Hello, wherever you all are. Thanks, Lynora. Yeah, it's a good question. So I will just put in the chat box for everyone the link to scheduled fit testing. So a couple things. My understanding is that if your size is in low supply, you are, I believe, being contacted for notified you need a different one. So your size, even though there are a lot of new things on the carts, should still be there. If it isn't and you need an alternative, I'm putting the link to the schedule for zone for doing fit testing. And you should also be able to reach out to the area manager, because there are some people doing on-site fit testing. So that I don't know, I'm calling it like a pop-up kind of a clinic model, but I'll put the info in the chat. Students have to do it through another process, so you can't help your student with that. But the bottom line is, and I'm in a Covenant site more often than the U of A site, but over here they're contacting me when my size is not going to be available soon. And obviously they're trying to reach people before that's the case. You shouldn't be on the situation where you go to a ward and you can't get your size.
Yeah. And then, Robyn, there is a question here about having N95s in the doffing stations, and this might be site specific. I know some people feel comfortable wearing their N95s all throughout the hospital, but they're only in the donning stations and not in the doffing stations. Any thoughts on that?
I just, as you said, I think probably better I don't. The flow of supply and the organization is out of my area, probably site specific.
Yeah. Okay.
I think at the U, there should be availability of N95s at both the donning and the doffing stations. And if there aren't, then certainly let me know and I can rectify that.
I don't know if whoever put that in wants to just put that in the chat, but I believe that it was, at least on 5D4, we didn't have N95s in the doffing area, but there might be other areas as well. Lynora, I'm going to throw this one at you. Can you help us understand the antigen widely used now in the community? I think that's a test, yeah. How long does it stay positive? When is the optimal time after symptom onset to do the combined swabs, and correlation with viral viability?
I can tell you what I understand, and I'll welcome the others pitching in too, because the data for Omicron is much less. So from other strains, it is clear that, the sensitivity of the rapid tests can be quite variable in the kind of 50 to 80% sensitive range, depending on the test. The tests that have been used most widely here, actually, the the green rapid response test, I never did end up seeing like a validating data. But for example, the PanBio test, which was also commonly used, was in the realm of 80% in most validation studies. And it does appear to be. There was one study that suggested might be less sensitive for Omicron. I've not seen that replicated, so I think it's very similar sensitivity to prior strains. So in the past, it was also clear that although you could test positive before or at the onset of symptoms, there was increased sensitivity at around day 3 of symptoms. And so there's also lots of cases, including one healthcare worker report, where they were doing paired rapid tests and PCR together for days, like over every day for several days, and quite a few people had 2 or 3 negative rapid tests paired with a positive PCR test prior to the rapid becoming positive. So you really can't rely on a single rapid test, and repeating it a day or 2 after is a wise thing to do. And if you actually are a healthcare worker and you're using that rapid test to help you make decisions, you probably shouldn't. What you should be doing is going to get a PCR test.
Yeah.
So they're good if they're positive. If they're negative, you can't really rely on them. And the other thing I'm going to comment on is, a test positive does not mean viable virus, and viable virus does not mean transmission. And so there really has been nothing to suggest that testing negative at any given point after infection gives us valuable information in terms of your risk of forward transmission. It just doesn't. And that there are some studies that suggest that a positive PCR test, especially, can be associated with dead virus quite quickly. And so positive test, I think, can be quite misleading later in infection. I think early in infection, a positive test, you can say the virus is there, you're probably infectious. But especially from, kind of a week out, the presence of a positive test does not really inform us as to how much that person might transmit, because detecting dead virus protein or dead virus nucleic acid isn't necessarily informative. I welcome others' comments on that, though. So I sound kind of nihilistic on the testing because, in fact, I am. I think that they're useful acutely if they're positive, and otherwise, I think that there's a lot of landfill full of rapid tests that have not helped us. Sorry.
Steph, you want to jump in, and address Anna's question too at the same time.
I would agree with Lynora that certainly the rapid tests do seem to be positive a little bit later than the PCR testing. It's just a little bit less sensitive, and so kind of probably day 2, day 3 is probably your optimal time in terms of rapid testing positive. And completely agree with testing later in disease course really doesn't give us a lot of information. Based on the study that I presented at the very beginning, looking at viable virus basically being absent at day 10, but PCR still being present, for weeks sometimes. I think we know that dead virus can be cycled up and be present, but it doesn't necessarily translate to forward transmission or infectivity. So I think the time to test is at the beginning, and I don't think that we should be testing to determine when we're clear.
So then, I guess to healthcare workers, and in terms of Anna Oswald has asked about continued testing after you've finished your 10-day isolation period, you would not recommend that you do a rapid test when you're coming back to work to kind of confirm that you're negative or anything, because it's not going to be helpful.
I mean, I think symptom resolution, and again, if you've had more than 2 doses of vaccine, then the recommendation is 5 days of isolation and symptom resolution, whichever is longer, and then you come back, and retesting really doesn't play into that algorithm.
Yeah, it's Robyn here. I'll just add, almost all of our healthcare workers are immunized. And so Anna's right that for those who are completely unimmunized, and there's a very small number across the province, there are testing guidelines as part of sort of a fit to work. But just as Stephanie said, this is after your 10 days, no, you don't retest or need to retest when you're fully immunized. Everyone should have their booster if they haven't already. And also, to Lynora's original point, not just using that PCR test to decide if you should work, but the symptoms. So if you have symptoms and you think you have COVID, even if your rapid test is negative, take it seriously. Go get the PCR. It's fast, usually. I know there've been hiccups, but it's coming. You'll get your results quickly, and that together with your symptoms should guide you.
Thanks, Robyn. Lynora, I think you want to jump in on this question about CT values.
Yeah,
those
that's
paired.
a particular study. I'll have to find a reference so I can share with Vanessa, but they were definitely infectious type CT values. So I know that there's kind of been a bit of there's been a little bit of lore that's arisen that, you know, a rapid test will tell you if you're infectious or not. And I think that remains questionable, and that we have to continually reevaluate the available data on that question. And that was actually a very concerning study to me, because so many, I mean, pretty much every single individual in the study had negative rapid tests with a low CT value for 1 to 3 days prior to having a rapid test positive. So it also does vary a lot between the tests as well. So it's I don't know. Every time people think that there's an easy answer to something, like the easy answer is N95 mask, or the easy answer is rapid test. As it turns out, there is no easy answer, and it's some combination of all of the above. Sorry to be a downer.
It's realism, right? Steph, do you have any comments on commercially available, those KN95s and 94s and all the rest of it? Is there? Yeah.
Yeah. So, I mean, you can certainly get in some places, although I think they're hard to get right now, KN95s. And the difference is that, the way that you do your seal check is a little bit different. So you can still actually fit it to your face, but the process of doing the seal checking is a little bit different. I think, at the end of the day, I think the main things that, I think we can really get into the weeds in terms of, N95 versus N94 versus KN95. And I mean, the main thing is that you have 3 layers of protection, and you have a well-fitting mask. And so those are probably the main things that I would recommend, is that it should be fit well to your face and 3 layers.
There's a question about RAT, and I know Karen has weighed in as well, that it has low positive predictive value. Any thoughts on anti-NC serology having a role for diagnosis? And I will just say that, we do have our long COVID clinic, and I wonder if some of that is to try and identify sort of when some symptoms are related to a previous COVID infection. Lynora?
I was going to say, I mean, others might have an update, but I mean, in the acute scenario, there'd be very limited use, I think, of that serology. But in terms of identifying whether someone has a post-COVID condition, and in, I guess, a very short list of clinical scenarios, that would be valuable. And the last time I checked at the lab, I mean, they have the anti-spike serology that is being used to help stratify people less and less relevantly for casirivimab and imdevimab. And then the NC serology, there is a panel that is a combined spike NC, and I think that they were validating it. I don't think that it was validated yet. My perception was that the people in the lab, if anyone's watching, weigh in, were aware that this is going to become something that's important for kind of retrospective diagnosis, mostly in that setting of a post-COVID issue. And that it would be likely something that would be valuable to be able to do at a relatively large scale if necessary, because I know a lot of people during this last wave were like, I want to know if I had COVID. It also might have implications in terms of the urgency of certain types of vaccine boosters. And so that's something that I think is perceived as being important, but we really do have to make sure that any test that the lab is giving us is a validated test, because there are a lot of garbage serology tests out there. And people are paying for garbage serology tests that are kind of uninterpretable.
Thanks. Robyn, I'm going to throw this one at you just to confirm that the fourth vaccine dose is only recommended for severely immunocompromised. Would you recommend for any other population?
Right now, the recommendations in Alberta and nationally in Canada are for immune compromised, yes. And the way it's worded is moderately and severely immune compromised, and there's a list of conditions, and I'll put the Alberta Immunization Manual in the chat. So the way that's framed is that the primary series for those who are moderately to severely immune compromised is 3 doses. So it's one booster. So one booster, which happens to be a 4th dose in that context. You will see there is one Canadian province where they're giving a 4th dose to people in long-term care. And there are some data from you'll see probably shortly coming from other places on that topic, a 4th dose for those in long-term care. And when you're thinking about that, I'll just circle back to last week when we talked about all of our unique contexts in our different countries. So that's not a recommendation here in Alberta. And so, yes, it's only moderately to severely immune compromised at this time. And people are looking at, whether more is needed. Last week, I tried to sort of comment. I'm hearing some people saying, we'll just get a booster everyone every 3 months. And I don't think so. I don't think that's going to be the way this goes. So it's not as though everyone's going to get 4th and we're just waiting for a moment. It's not like that.
Yeah. Steph, can you remind us about how long immunocompromised patients should be isolated, whether they're inpatients or outpatients?
So, yeah, it's a good question. So in the inpatient setting, then we are still recommending that severely immune compromised patients be isolated for 21 days. And that is based on evidence that we see that they have fairly prolonged viral shedding with very low CT values. So, CT values in the kind of 20s, even sometimes up to, 3 weeks out. So in that population, we're still recommending 21 days. In the community, the recommendation is 14 days kind of across the board for immune compromised patients.
Okay, hopefully that answers Anna's question. We have 2 minutes and I have this panel, so I have to ask. So, you talked about all the therapies. We know that all of these are so expensive, right? And Lynora, you put in a little comment about giving vaccinated versus unvaccinated. And so have there been cost-benefit analyses done with these? I mean, I've seen some reports here and there, but any thoughts about this?
I can speak to that a little bit. And, it's interesting because COVID has kind of created a whole bunch of things. Things happen that not the way they usually have. So things are being approved without having, an actual full access to the data. I mean, it's all been crazy. In US-based cost analyses, most of the new therapeutics are coming in just at the line, at the cutoff. If you look at the cost analyses that are, the type that we look at more in Canada and in the UK, some of them are too expensive. And I think that as this settles down, if we're moving to a position where we're going to have some circulating COVID and occasional severe cases over the long term, we will be circulating back to everything that's on formulary and re-looking at the data and looking at the economic impact of all of the treatments. And so, that there's been a complete subversion of usual processes, and there's going to be a cycling back to that. And I do think that there will be there will be some agents that might not end up becoming commonly used for those reasons. But we'll kind of see also. I mean, it's a changeable situation, and some of the therapeutics are coming in at a level that would not usually be approved for use within AHS.
Yeah. Robyn or Stephanie, do you want to add?
Well, I'll just maybe add one thing. Vaccine is our best vaccine, and prevention is our best with that lens as well. You're going to see lots more on cost comparisons. We're going to be studying all of this for years, as I'm sure you all know. But vaccine is the affordable way. So if you've got some friends you're still trying to convince, don't lose hope. Keep the conversations going.
Yeah, I would agree. I mean, I think that it's pretty clear that, in a very small subset of people, these therapeutics are important and will keep them out of hospital. But when you look at the absolute risk reduction, we're looking at 6%, 7%. And when we look at the efficacy of vaccine, it's, much, much greater than that. So I think we need to keep that perspective and understand, and I agree with Lynora that we probably do need to have a more in-depth look at kind of cost analysis and where, what population it really does make sense to use these fairly expensive therapeutics.
I'm sure you can see all the comments in the chat box. We are so fortunate to have the three of you this was really fun. We need to do this more often. I'm really happy we did the second week. For these three, they not only are on their phones and answering calls in the media and all that all the time, they're also providing clinical service and, continuing their academic work. So on behalf of the department, thank you guys so much. This won't be the last time we see you. And have a great, safe week, everybody.